Successful care transitions or successful or succession models, are currently under development, and those models will vary depending on the type of the organization. So organizations that insure all of their patients compared to organizations that are fee-for-service, compared to organizations that are part fee-for-service and part ACO where they insure their patients, will have different models of transition. As there are new reimbursement codes for transitions of care. So it behooves most organizations to have a successful transitions of care model where you touch the patient within 24 hours of discharge, then you see them in the office within 3 to 5 days of discharge to make sure the patient has an appropriate care plan in place. So there is reimbursement. CMS has identified that as a huge gap in patient care. That's why they developed the TCM, or transitions of care, billing process to reimburse clinicians for something that previously was not reimbursable. So we were utilizing resource and not being reimbursed for the time that it was costing for that. But successful models will have a multidisciplinary team that can take care of the patient for the patient needs. So it's patient-centered. So each patient is different. So each patient has a different need. They have different understanding, and making sure that each team will need to have the multiple resources available to take care of that patient, depending on the variations in the patient care. So which patient population are non-adherent to therapies or more likely not to be adherent to therapies? Examples of that are patients that have a low education status, patients that have not accepted their disease, do not understand the severity of their disease and the consequences of not managing the disease. I don't want to put a stigma saying that it's a low socioeconomic class. That's not always the case. We're finding that different generations want to be taken care of in a different way. So let me answer it this way, where patients such as the millennia population, they do not want to have scheduled appointments, nor do they want to come in for office visits. They want to be taken care of by their electronic device they carry around every day. So they want us to push information to them through the electronic device, and they also want to communicate to their health givers back into the electronic health record or secure text messaging, some electronic method to their healthcare providers. The middle generations are varied, and some of the middle generation are tech savvy, and they also want that IT connection to their medical team. Others still believe, and they've grown up with the face-to-face visit with their healthcare team. They do not even believe in a phone call follow-up. So they would rather come in for all of their care. So putting the patient at the center and developing a process for taking care of patients the way the patient wants to be taken care of is where we need to be. So we need to tailor it for each individual patient. We've designed healthcare around the clinician, and then the patients have had to essentially mold to that process. We need to redesign healthcare where we need to care for the patient the way the patient wants to be taken care of or cared for, but also giving the patient the best practice limitations. So not just allowing the patient to decide, even though we push that we know that what the patient wants is not best, and if it's putting the patient at harm, we need to make sure the patient understands that. Will technology, mobile health, change the way we deliver healthcare? Yes. So we're already seeing that change. So publication here several months ago about patient-entered information, publication about patients having access to their electronic health record to view and read the progress notes of their clinicians, to essentially read over what was discussed at their visit, is now we're showing as a benefit. And also the communication from the patient back to their healthcare team, we're able to garner or obtain information about the patient that we would have missed or the patient would not have freely given us during an office visit, that they'll freely give to us at their time of, when they're at home, in the comfort of their own home, be able to take their time to answer us. So I'll give an example. Patients' medication lists. So we think of medication lists as pretty simple. As we see our clinician, they ask us what medications we're taking, they update the medication list in the electronic health record, and we assume that's gospel and that the information is correct. But what we're finding out is that the patient's medication lists in the electronic health records are actually accurate about 30% of the time. Why is that? Well, when we see a clinician, patients do not want to fail their physicians, number one, so they're not always honest with them. Number two, if we make a dosage change or we add a prescription to a patient, once they leave the office, we really have no idea what the patient, as a clinician, we have no idea what the patient is doing unless we have feedback from the patient. So if we were give the patient a new prescription, if they can't afford it, if they start it and they have a side effect, or if they read on the internet that it has a side effect, or their neighbor tells them that their aunt died from the medication, they stop it. If we don't have patient feedback, we're not going to touch that patient again for the 3 or 6 or 9 months at a scheduled traditional managed practice where the patient will have a traditional appointment coming back. But if we have a model where the patient can communicate to us if they're having questions, if they go to the pharmacy and the patient cannot afford the medication, they don't fill it, the patient may not communicate back, but why can't the pharmacy communicate back that patient was in the pharmacy today, they wanted to fill the medication, it was too expensive, so they didn't fill it? So why rely on the patient? The pharmacy or pharmacist communicating back to the clinician to make sure the patient's medication list is correct. So what we think the patient is taking to manage the patient's chronic disease is actually what the patient is taking. So I could talk for hours discussing that topic.